A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Now this is the lecture on bronchiectasis for the final year MBBS students. I am a facilitator Professor Sayyid Ali Haider. I am visiting professor of medicine at JSMU, Karachi, Pakistan. Definition of the bronchitis is that these are the irreversible bronchial dilatation. Bronchial dilatation, the division of the bronchi, vestibular bronchus, lobar bronchus, globular bronchus, and segmental bronchi. Segmental bronchi will divide and then form the bronchioles, and then terminal bronchiole, and then alveolar space. So these are the irreversible bronchiolar or segmental bronchi, or in some globular bronchi, in some case it is the lobar bronchi, even are involved in some cases. So this is but their dilatation, they are not temporary, they are irreversible. Irreversible. Radiological or pathological diagnosis should be made to confirm it. Otherwise, clinical is definitely more applicable, because I have diagnosed this condition many times without any radiology or any pathological diagnosis. HRCT scan is the current gold standard, although here coming the lack of confidence of the physician. More are the investigations, you irritate the patient. Cost effectiveness of the management plan, and patient will not cooperate. According to the patient, a lot of tests has been done, and no treatment still is on the initiating phase. I am just waiting for the results. He said that, and then the doctor said that he will start treatment. So where is the clinical knowledge is gone? Clinical knowledge is buried inside the earth. Clinical examination and history taking and physical examination, I mean to say that, differential diagnosis, etc. People don't like, in most of the part of the world now, they form shortcuts. And by the heart. By heart they want to learn. Can you satisfy the patient in this fashion? To me it is not possible. Now my clinical experience is more than 45 years. I am doing clinics with seniors, with other people, become a more senior man and more senior man and more senior man, until I am now at this stage of my life, that I am a senior professor of internal medicine and clinical cardiology. I am sorry to say that the students, they want shortcuts. They don't like the discussion. They don't like the problem-based learning, which is the good way to achieve knowledge. Nobody has consulted me, because I am not charging anything. Now, how the medicine can be learned, nobody has asked me ever. During I think last 10 years, how can we become more expertise, for example. Now this is the chronic suppurative disease, symptoms of the chronic endobronchial suppuration. Inflammation is there, it is a suppurative type of a disease. And because the suppurative type of disease, this is definitely obstructive in nature. It may be radiological evidence of bronchitis, may be positive, may be negative. Etiology. Now, chronic infective bronchitis, protective bacterial bronchitis. Prolonged bad cough, resolve promptly after treatment if untreated may progress to the bronchiectasis. This is a clinical type of the etiological diagnosis, you can say. So these are chronic bronchitis, productive type of the cough, completely after treatment, but if untreated, they progress to bronchiectasis. When the chronic bronchitis leads to bronchiectasis, it means chronic suppurative lung disease, best overarching term. In any suppurative disease in the lung, which is infecting the lung, the bronchiole or the lobar bronchi or segmental bronchi or lobular bronchi. Now this is the one X-ray, inspiratory and erect position, very good X-ray which is done. Out of 100 students, only 2 students of mine was able to describe it properly. All are failed. If I describe this X-ray, I will take time. Mentioning the important thing is the bronchovascular markings. Look, these are coming out and ending here at the lateral 1/3 till here, touching it. So these are the bronchitis changes, or which will usually written in the reports. Now further here, this you see, now these are the fine reticulations which are coming out. Look, these reticulations are marked like this, and they are crossing here and making holes. The reticulations making crossover, bridging, making these holes. This is a part which is involved, and that is honeycombing effect, that is called. It is difficult. If you see in the magnifying glass, you see this like a honeycomb. Here is upper lobe divergent is also there, pressurizing the heart also. Now here you see bronchi and bronchioles are involved. That here the bronchi, here the bronchioles, they are involving and forming the same thing, I will say, the network, the reticulation forming the honeycombing, crossover bridges. This is very clear honeycombing. On the CT you will see the changes gradually. These are the bronchi. This is the lung window, which is, they are not mediastinal window, it is a lung window. And since you see this lung window and mediastinal windows are different. Now here they are definitely seen, this is how the dilatation is seen, secular type of a dilatation. Here again the cystic type of the bronchitis is shown here, where even the so much so the stasis of the secretion make the what we call as the fluid levels are seen. Here. This is cystic type of bronchiectasis. Again here you will find the honeycombing is there, and this is the network which is there, varicose type of bronchitis. Fusiform bronchitis, cystic bronchitis, secular bronchitis, varicose bronchitis, depending upon the radiological appearance. Pathogenesis, obstruction leading to chronic inflammation, damage, dilatation of the bronchial walls, abnormal cartilage formation, congenital causes are there also. Common thread is the difficulty clearing the secretion plus recurrent infections and resulting airway injury and remodeling process going on, and fibrotic reaction will take place. Infections and an ineffective host immune response involving the uncontrolled recruitment and activation of inflammatory cells. First of all, neutrophils, followed by the lymphocytes, followed by the histiocytes, followed by the fibroblasts. The release of the mediator, for example, proteases and the free radicals. Now these mediators are called the weakness of the wall, and that is called dilatation, injury and dilatation. Causes are manifold. Some are written congenital diseases out there. For example, alpha-1 antitrypsin deficiency can cause it. It is a congenital cause. And the cystic fibrosis, immune deficiency, it may be IgA deficiency, it may be IgG deficiency, or it may be more than that, immunity deficient of the whole chain, IgA, IgM, IgG. Primary ciliary dyskinase, yes. These are the group of diseases. The ciliary movements are very weak. Cystic fibrosis is one of the cases. Carter syndrome also. But this is secondary. This is primary. Primary means that the cause is not known. Aspiration, recurrent, small volume. Aspiration will cause the obstruction. Recurrent aspiration occurs in old age. Small volume will go inside. GERD can cause the aspiration, GERD, and causing the infection there, weakness of the wall and dilation. Post-infections like mumps, measles, etc., acute viral infection, acute bacterial infections, even some of the parasitic infections can cause the bronchiectasis. Can somebody name one parasite which causes the bronchiectasis? Anybody in the world that causes the bronchiectasis? It is Trypanosoma cruzi which can cause the bronchiectasis. And the systemic inflammatory diseases, for example, rheumatoid arthritis, Sjogren's syndrome, systemic sclerosis, where there is fibrotic changes occurring, weakening of the wall occurs, and dilation, and stasis occurs, and again the same picture will come. One is the cystic fibrosis. For you, it is the autosomal recessive disorder. So autosomal recessive disorders it is. Means skip will be seen here, skips in the siblings. First generation, then second generation, third generation skip, second generation skip, third generation are involved, fourth generation skip. And the chromosome 7 is involved in this case. And the primary problem is CFTR, that is the cystic fibrosis modulator. It is a modulator transporter. Transport CFTR regulation. Transport modulator. It is the CFTR lacking in these patients. The ciliary action is gone. If it is gone, it means that everything will be cannot clear it or speed up. So many organs are involved. Sinuses, sinusitis, lungs are involved with the same bronchiectasis. Maybe emphysema is possible. Skin involves sweat glands produced because exocrine glands. It will be salty sweat because of the chloride. They are blocked. Channelopathy, which is I call it the channelopathy, with CFTR deficiency, and it comes at the chromosome 7. Liver, because biliary ducts have got cilia, and they are blocked. Pancreas, again the exocrine pancreas is affected. Afterwards, the endocrine part will also be affected afterwards. Intestine, again the malabsorption. Because of the villus, they cannot work properly. Reproductive organs, male and female both, male has got a vasa deferens, you know that it should be a ciliated epithelium, and the sperm will travel through with the help of the cilia. Hypometrically, the cilia will cause the patient infertile, not impotent. Female can become pregnant, no problem. If the in vitro fertilization, there's possibility that she may become pregnant. male, the same one, in vitro fertilization can be a possibility. There are a lot of complications in the lungs. Some very, very specific bacteria are seen of Pseudomonas, Proteus, and Burkholderia specia. These are the very rare organisms which are causing infection in the lung, which becomes only seen in the cystic fibrosis. So these persons, which called cystic fibrosis, have got the cough, productive cough, very purulent amount is coming, high amount is coming out, and because of the infection, clubbing will be there, fever off and on, loss of weight, delay in the milestones, malabsorption will cause all vitamin deficiency, specifically speaking, the lipid-soluble vitamin will become A, D, E, K deficient, and infertility. And lastly, pancreas is involving here with the endocrine pancreas. Destruction occurs, and the 10 to 25% of cases will end up with the destruction of the pancreas and will cause diabetes mellitus. Investigation, the CBC, immunoglobulins levels, sweat test, it is the test how much chloride is there. Absent, sodium will be increased. Sodium content of the test of the sweat is increased. Chloride is not even found. It is very least amount. Sputum examination for the same to exclude other diagnoses as well. And the axial fractional nasal nitric oxide and our nasal ciliary brushings. These are the group of testing which is not done in Pakistan. Spirometry and the lung volume, that is the lung or pulmonary function test. Here you see the test will show you the reduction of the FBC, FEV1 and the ratio in obstructive lung disease, while the residual volume and the total lung capacity will become decreased. Further investigation, see a gene mutation, you can go bronchoscopy for any foreign body, acute, if this is an acute problem, airway abnormality, barium swallow, further tests, they become IgE tests and others, HIV, excluded because the infection of, there are different infections in the lung with HIV and which can cause bronchiectasis. And the echoviruses, echocardiography will, especially in the adults, to exclude the pulmonary hypertension, the echoviruses will cause this condition also. Here echocardiography. Assessment of severity, clinically cough is productive, much cough is coming out. Patient will be worried how much sputum is actually coming out, where it is produced. There is a factory in my lung which is producing so much amount, 1 liter, 1.5 liter of sputum, especially in the morning time. Exacerbation rates are there, sometimes it is symptom free, sometimes it is much cough. And depending on the well-being, because he will not work properly, and everyday life is definitely difficult for him. Severity, you go for the spirometry. I already said that you give the pulmonary function test. It will reveal the obstructive nature of the disease. 6-minute walk assessment, functional impairment. You can do like that. Microbiology, the common pathogen includes the hemophilia influenzae, the Streptococcus pneumoniae, and microbe, and the Moraxella catarrhalis, that is commensal in the nasal mucosa. Here it is pathogenic. Even Klebsiella pneumoniae can cause, when children is concerned. The management, early and effective management reduces the short and long-term morbidity. Management is the airway clearance, chest physiotherapy, postural drainage, nutrition should be good, otherwise patient will lose weight. Fitness and activity will be promoted. Avoidance of environmental pollutant, tobacco, second-hand tobacco, active smoking, or vaping, etc. Environmental pollutions, avoidance of this. Face mask should be used. Assessment for the comorbidities, if they are present, it should be addressed. And annual flu immunization should be done for the pneumococcal vaccine and the flu vaccine, that is the influenza vaccine. Antibiotic treatment should be given, broad spectrum antibiotics will be given for a prolonged period of time. I have managed these cases with 1 month like this. Long acting drug I used for 1 month, then second long acting, I changed the antibiotic, and third month I changed the long acting antibiotic. In this fashion, I manage these cases, and there is much improvement of the cases. In cases of the cystic fibrosis, the sputum is very thick. They use Dornase, DNase. There is a substance which is called Dornase, costly item, but it will definitely, it is a very, very important mucolytic type of effect on the sputum, and it will liquefy the sputum, Dornase. So I thank you to listen. My lecture, this brief account has been given to you. It is part of the COPD, polar ends between emphysema and chronic bronchitis, bronchiectasis. I have dealt it. If you have any question, you can go for the WhatsApp group. It's called, or you go and comment on this presentation and ask questions. If you want to learn medicine, I don't want, because I am just uploading this lecture. I don't know who want to see or who don't want to see. Because before my death, I want to complete the internal medicine in this fashion. So I say goodbye and wish you good luck for the future. Assalamu alaikum wa rahmatullahi wa barakatuh.